Hello, everyone, and welcome to Behind the OR, the Peter Surgical Podcast channel, where we invite experts to reveal to us what's happening behind the closed doors of the operating room. Together, we will explore surgeries and procedures and discover more about a surgeon's life in their daily mission. Take off your gloves, take a breath, and let's talk behind the OR.
Welcome to Behind the Operative Room, a series of podcasts in which we talk about the fascinating world of cardiac surgery. I am Bleri CELMETA, a cardiac surgeon working in Galeazzi-Sant'Ambrogio Hospital in Milan, Italy, and I am thrilled to have you join me today. Whether you're a cardiac surgeon, a cardiologist, an anesthesiologist, a perfusionist, a person involved in the assistance of cardiopathic patients, or you're just simply curious about what's concealed behind the cardiac surgery's operative room, you're in the right place. In today's podcast, we'll dive in a journey through the complex and fascinating history of cardiac surgery. In a more classical point of view, we generally need to stop the heart from beating in order to be able to perform the surgical correction of the cardiac disease. But to be able to guarantee the survival of a patient with an arrested heart, we need a specifically designed heart-lung machine, which after being connected to the patient, replaces the pump function of the heart and the oxygenating function and the carbonium dioxide removal function of the lungs. In this way, the surgeon has the time to perform the planned surgery with a non-beating heart. But you see, the cardiac surgery as we know it today is a relatively young specialty. Until the end of the 19th century, the surgical community around the globe had always proclaimed that nature had placed the heart beyond the reach of surgeons, and that any surgeon who would operate on the heart would lose the respect of his colleagues. It was really a forbidden surgery, but why? In the not-so-distant past, each attempt to surgically correct heart diseases concluded almost inevitably with the death of the patient. In a world where the cardiopulmonary bypass was yet to be invented, the surgical opening of the heart cavities concluded in the majority of the cases with the death from massive bleeding or from air embolism. The transfusion medicine and all its principles were yet to be discovered, so rapid reinstitution of the lost blood was not possible. Moreover, with a lack of minimal hygienic and antisepsis procedures among surgeons, it's easy to imagine a really high rate of deaths due to infectious complications. A complete open heart surgery would never have been possible without the simultaneous evolution of numerous branches of the medicine and basic surgery. For instance, surgeons did not have mastered yet the vascular anastomosis techniques, so interventions on the aorta or other vascular structures were not possible. I want to share with you the story of an inauspicious event which led to a fundamental piece in global surgery. In 1894, during festivities for Exposition Internationale et Coloniale in Lyon in France, the popular French president Sadi Carnot was stabbed in the abdomen by the hand of an anarchic insurgent. The techniques commonly used by the surgeons were not able to guarantee the repair of the resulting laceration of the portal vein, leading to the president's death for hemorrhagic shock. The traumatic event impressed so much the young assistant surgeon Dr. Alexis Carrel to the point that he would afterwards dedicate all his life to the improvement of the vessel's anastomosis techniques. The triangulation technique was born, the transformation of a single suture of a circular structure to 3 sutures of an equilateral triangle facilitated the procedure and guaranteed an enormous advancement in the field of vascular and cardiac surgery, in particular in the transplantation surgery. Almost contemporarily, the first successful cardiac operation was performed in 1896 by Dr. Wren in Frankfurt. The patient was a 22-year-old gardener who had been stabbed in the thorax, causing a heart perforation. In an extreme attempt to save his life, Dr. Wren performed a right thoracotomy and placed 3 sutures on the lacerated ventricular wall on a beating heart. The patient recovered completely and was discharged home. Just a little reminder for the listeners, the first recorded cardiac surgery in the modern history was not performed in full sternotomy, but in thoracotomy. This may come as a surprise for the majority of modern cardiac surgeons, as we are used to regard at full sternotomy as the standard approach. Returning to our story, In the following years, other surgeons started reporting similar successful surgical treatment of the traumatic heart perforations. All of a sudden, surgery of the heart was not regarded as forbidden, but as an opportunity to advance in this groundbreaking frontier. Despite the first successful attempts, time was not mature for cardiac surgery to develop to its fullest. A fundamental aspect to be resolved was the pulmonary ventilation. In fact, as soon as the pleura was opened, the homolateral lung collapsed immediately due to the atmospheric pressure being superior to the intrathoracic one. This caused an important hypoxemia, leading in some cases to death due to respiratory failure. In order to avoid this, in 1904, Dr. Sauerbruch invented the so-called universal negative chamber. In this setting, the head of the patient remained outside of the chamber, permitting to breathe air on atmospheric pressure, while his body and all the surgical team remained inside a negative pressure chamber. The atmospheric pressure in the patient's alveoli was greater than the negative pressure of the surgical chamber, so the lung did not collapse at pleural opening. So you can see that this was an effective but extremely costly and complex solution. As soon as the orotracheal intubation and positive pressure ventilation was described for the first time in 1909, the universal negative chamber concept was abandoned and the general anesthesia with oral intubation became the standard for all cardiac surgery operations. In order to perform a successful surgery, a precise diagnosis derived from efficient diagnostic tools is mandatory. The time period between the two world wars was fundamental for important advancements in radiology and electrocardiography. In 1929, a young assistant surgeon named Werner Forssmann, with the intention to administer intravenous drugs directly into the heart chambers, inserted a thin catheter on a peripheric vein of the arm and pushed it forward until it reached the heart cavities. The chest X-ray, which he subsequently performed to himself, clearly demonstrated the presence of the catheter in the cardiac chambers. At the time, the scientific community strongly believed that cardiac catheterization was not possible on a living being, so the possible implications for the Forssmann experience were terrific. All of a sudden, with the infusion of contrast medium, cardiac chambers morphology could be revealed and the intracardiac pressures could be measured. Moreover, intravenous drugs could be instilled directly to the heart, avoiding the local complications of some cytotoxic drugs. Despite all of this, unfortunately, the academic community response was extremely severe. Forssmann was heavily criticized for the apparent lack of reliability and professionalism, while different cardiac surgery chiefs refused to employ him, in particular one declaring that his hospital was not a circus. Forssmann abandoned completely the heart surgery to become a successful urologist. It was many years later that his work and foresight received the deserved importance. In 1956, after some 30 years, for all the implications in cardiology, clinical and surgical field, he was granted the Nobel Prize in Medicine. In this first episode, we talked about the genesis of our specialty. In our day-to-day rushing hours of clinical practice, we almost always tend to take for granted so many standard procedures for which decades of research, sacrifice, and human genius were needed. The story of cardiac surgery with the first coronary angiogram, the race for the development of the first prototypes of cardiopulmonary bypass, the establishment of the cardiac surgery as a routine and safe solution for complex and fatal heart diseases, and more topics will continue in the next episode on the Behind the OR podcast. Thank you again for being with me today and stay tuned for more episodes.
Let's meet at EX 2024 in Lisbon on the booth 230 to discover more about surgery, education, and innovation.